Could I ask you to start taking your seats, please, and we'll start the session very shortly. Thank you. Just to say again, if you could please take your seats and we'll get started in about a minute's time. Okay, we're going to get started. Welcome everybody to this ministerial panel, for which the title is Action on MDR Tuberculosis as an Antimicrobial Resistance and Health Security Threat. My name's John Watson. I work for Public Health England in the United Kingdom, and until recently was the Deputy Chief Medical Officer in the United Kingdom. We have a session which will include short presentations from 4 ministers who I will introduce, as well as a presentation from a representative of civil society and from USAID. Each has been posed a question, and I will put that question to them before they speak. Unfortunately, 3 countries were unable to send ministers, according to the original plan, but there are representatives of 2 of those countries in the audience, and if there is time, I will give those representatives an opportunity to say a few words as well. After that, I will open up to questions from the audience, and we will see how time goes. So by way of introduction, we have heard a number of times about the headline statistics about tuberculosis, including the number of multi-drug resistant cases that occur each year. But this needs many repeating. The fact is, there are estimated to be about 500,000, 500,000 new cases of multi-drug resistant tuberculosis occurring each year. Of those, only 150,000 are detected, and of those, 130,000 started on treatment, and of those, only about 50% successfully treated. So let's just turn that round. That means of 500,000 new cases each year, only about 70,000 are successfully treated. That is 14% of that total. This leaves 430,000 cases of multi-drug resistant tuberculosis each year who are neither detected nor successfully treated. And what happens to those? They may die, they may have chronic disease for many years, and many of them will go on to infect others. All countries have cases of multi-drug resistant tuberculosis, but we know that there are only some countries that have a really high burden, and it is on those that we are going to concentrate today, and we will hear from some of those countries in this session. In 2015, WHO declared multi-drug resistant tuberculosis a global health crisis. And on the slide that you can see the 5 priority actions that WHO have recommended in relation to Mdr-Tb. What is clear is that Mdr-Tb cannot be managed as business as usual. There are all sorts of other implications of Mdr-Tb, particularly cost to the state and cost to the individual. There is a substantial impact on poorer communities, impact on poverty. There is an impact on employment. There are issues of stigma, implications on migration, and other issues as well. As part of this session, WHO have put up on the website and the app for this conference a short questionnaire about Mdr-Tb, and I invite you all to go to the app and to the website and look at that questionnaire and the 2 questions it poses, and complete your answers to the question. So, the aim of this session is to explore ways to secure political commitment to accelerate the response to Mdr-Tb. We need to draw on the lessons learned and take the opportunities that are now present. We need to make explicit the links between Mdr-Tb and the response to Mdr-Tb and the global response to antimicrobial resistance generally. And so I am going to turn to our panel, and the first person that we are going to ask to speak represents civil society and comes from the WHO Civil Society Task Force. And so can I ask Violeta Ross to begin with her opening remarks. Violeta.
Okay, good morning. My name is Violeta. I am from Bolivia, which is in South America. I am a person living with HIV, and the reason why I think it's important to be in this panel is because I don't want to be a person who dies with TB, as it's happening with many of those people living with HIV around the world. As you know, TB continues to be the main killer of people living with HIV, especially Mdr-Tb, and we are not being able to respond to that challenge. That alone to talk about one of the vulnerable groups to TB, which is people living with HIV. So taking on the remarks of the chair and what is already on the preparation of this panel, we cannot manage this challenge of Mdr-Tb as business as usual. So therefore, I'm here to tell you what civil society are ready to do, which is in the first place, we are ready to be partners and not only patients. For a long time, we have been patients and treated by many of ourselves in this conference like patients, you know, which our own responsibility was to take the medications. But now, I think we gain experience. There is a global coalition of TB advocates. There are groups around the world. You've seen them, all these presentations yesterday and today, doing advocacy, doing resource mobilization, so we can do much more than just being the patients. We want to be partners in the response to this challenge of Mdr-Tb. So what we are ready to do as civil society groups working or living or affected by TB. First of all, we want to, and we can, demand comprehensive patient-centered care programs. We were just in another panel listening about the challenges of human rights for migrants. We still know, and all of you maybe agree on this, that there are so many challenges on human rights, especially on MDR. Human rights are not necessarily a framework that we use for the response on TB, equity, and the protection of the most vulnerable groups. Just to mention people with HIV, migrants, women, children, indigenous people. So this is one thing that we can do. I think you all know the roles of civil society around the world. We are very good at demanding, so we are going to begin demanding more of human rights, equity, gender equality, in every response that we present for the Mdr-Tb challenge. Secondly, we also will advocate for more political will, a drastic increase on political will. Your presence here, ministers of health of different countries, is very important, but not just in a conference like this. Also what happens at country level, it's super important. We know sometimes it's very easy to come to these kind of meetings, you know, to take the pictures, and then when we go back to our countries, we don't even get a response to our letters, or it's very difficult to meet you or have a meeting with some of you in our countries. And why do we want to meet you when we are living there in our countries? Because we want more money. All of this can be, you know, just very rhetoric. Oh, yeah, we know about TB, but if we don't allocate money, and I'm talking about the global level, the regional level, but also domestic funding for more research, for sustainable policies, for better diagnostic tools, treatments that are less toxic, then all of this is just, you know, a nice conference and a nice picture that we took in Moscow or Berlin or Guadalajara, anywhere. I know the difference a better diagnostic tool can make in the life of a person who doesn't have access. I am a member of the communities delegation in the UNITAID board, which is investing in GeneXpert, for example, and I've seen the difference it makes in countries for people in real life. And the other issue is accountability. This is not a favor that we are asking, this is an obligation. It is written in our constitutions, it is a social justice. We put it in the Alma Ata Declaration, but accountability not just towards the government, but also to our own selves. I am referring to people affected by TB, community, civil society, because we are getting more attention from the world. Some of us are getting funding, and we want to be a partner, as I said in the beginning. So this is what I wanted to bring to your reflections. We are ready to help. We know the challenge is super important, especially when we talk about the context of antimicrobial resistance. MDR is not something that we can do alone, nor the government, nor the donors, nor the communities. We need to join hands, and we are here to help. Thank you.
Violeta, thank you very much for that powerful opening statement. Thank you for reminding us about the important relationship between TB and HIV, and for emphasizing those three issues about the importance of that partnership between people with TB and those who are engaged in fighting TB, and the need to work together. The need for increased political will, which is not just the political will that is shown at a meeting like this, but when you get home in your home countries. And thirdly, the importance of the accountability and the participation of civil society in that accountability. So thank you very much for that. I'd now like to turn to our first ministerial panelists, His Excellency Valeriy Malashko, who is the Minister of Healthcare in Belarus. Please. And sorry, if I may put the question that has been posed to you to remind the audience, and forgive me whilst I find that. Gone. Could I just suggest that you carry on, please?
I
think I'll concentrate on the measures taken in the Republic of Belarus aimed at reducing the high level of Mdr-Tb in Belarus. Distinguished chairperson, esteemed ladies and gentlemen, dear colleagues, first of all, I'd like to thank the organizers of the conference for the superb organization shown us at this forum. I'd like to thank the World Health Organization and the Ministry of Health of the Russian Federation for the superb conditions here at this conference. Of course, fighting Mdr-Tb is one of the priorities in the Republic of Belarus. We were the first in Eastern Europe to conduct an observational study using the WHO methods, especially to detect the level of Mdr-Tb among first treated patients and patients who had already been treated. We have a special policy to fight Mdr-Tb in Belarus, and there are three major areas here. First of all, international, intersectorial, and interagency interaction, patient-oriented approach to providing TB services, and third, creating an effective system of financing anti-TB arrangements. As for the first area, the Ministry of Health is cooperating with the WHO, the Global Fund, and other international organizations. As for the major features of our policy, it is based on openness and transparency. We are very grateful to any international technical and financial assistance. We try to implement all WHO recommendations. One of the major aspects was the regional HIV-TB treatment for all. Meeting in Minsk, the joint statement was adopted on the basis of this conference while providing access to anti-TB and HIV drugs. Starting from 2016, we have started the third program aimed at TB control, as well as the program of technical assistance for 2016 to 2018. We got the third grant to finance this program. Within this programs, we maintain interaction with different agencies and the civil society. We hope that the Global Fund will provide us with the new grant for 2019-2020 in order to fill in those gaps that cannot be financed from the state budget. The second approach, the patient-oriented approach, allows us to enhance the efficacy and to reduce the spread of Mdr-Tb. Here we have different programs, including controlled take-in of drugs, also arrangements of infectious control in all TB clinics and dispensaries, treatment of tuberculosis according to international protocols, as well as integrated assistance to the patient at inpatient and outpatient clinics settings. Well, of course, the social support is especially important as far as chemotherapy is concerned. Soon our country will adopt special documents for treating patients who have tuberculosis. Due to the WHO Euro, the Global Fund, the Republic of Belarus was one of the first countries in the European region that now can treat new anti-TB drugs, Mdr-Tb, Belomanid, and clopazimine, as well as other drugs. Currently, treatment with these drugs is given to more than 800 patients. Soon we'll purchase more drugs like this to provide new regimens of treatment with Mdr-Tb and Xdr-Tb. Third, in order to have an effective system of financing to control TB, we reduced beds, and now we will be treating these patients in outpatient settings. In order to improve the situation with combating TB, especially in Eastern Europe, we started together with the WHO pilot project to test a new model to finance the anti-TB services. We hope that the implementation of this project will allow us to switch funds from treating patients in inpatient settings to outpatient settings, and thus improve the situation of treating patients with Mdr-Tb. Thanks to different events and international assistance, we have improved the situation with tuberculosis in the Republic of Belarus. The drop of mortality rate over the 8 years was by 65%, as well as the morbidity rate. There was a reduction in the number of patients with Mdr-Tb. The efficacy of treatment with Mdr-Tb has improved. The coverage rate is almost 90%, and also there has been an improvement of treatment of patients with Xdr-Tb. The use of new anti-TB drugs has increased, and the number of patients sent for mandatory treatment was reduced by 3.6 times. We hope that due to the measures taken and the international support, the Republic of Belarus will be able to achieve the WHO goals to end TB and to successfully treat Mdr-Tb in 80% of cases. Distinguished participants in the Global TB Conference, the Republic of Belarus supports the draft declaration. I am convinced that only through concerted efforts we'll be able to achieve positive results and to win this fight against this terrible infection. Thank you very much.
Thank you, Minister Malashko, and thank you for answering the question that I failed to put to you at the beginning, and answering that so well. Many of you will know that Minsk, the national capital of Belarus, was declared some years ago as the global capital of Mdr-Tb due to the high notification rate of disease. But since then, Belarus has made remarkable progress in adopting global WHO policies and in pioneering TB and Mdr-Tb innovations. And I think we heard very well from the Minister what Belarus has been doing to accelerate the progress in this area and to achieve the targets of the NTB strategy for TB, including getting very high rates of cure rate for Mdr-Tb. So thank you very much, and I welcome your comments. We go now to Bangladesh, and I welcome His Excellency Mohammed Nasim, the Minister of Health and Family Welfare in Bangladesh. The response to Mdr-Tb cannot depend exclusively on what national governments do, especially when private healthcare providers serve a significant proportion of the population, as is the case in Bangladesh. Some experts believe that the control of Mdr-Tb in Bangladesh depends on the performance of the private sector. What changes in your plan are you proposing to introduce or are introducing to ensure that all people with Mdr-Tb attending the private sector can be diagnosed, cured, and accounted for. Thank you.
Thank you, Mr. Moderator, Excellencies, and honorable audience. Bangladesh is among the 30 TB and Mdr-Tb high burden countries of the world, with 1.6% Mdr-RR TB cases among new cases and 29% among previously treated cases. According to Global TB Report 2017, the estimated incidence of Mdr-RR TB is 5,300 in Bangladesh. In terms of case detections, the scenario of Bangladesh is not different from the global scenario. Only 1 in 5 estimated Mdr-Tb cases are being diagnosed. The NTP in Bangladesh started implementing the programmatic management of drug-resistant TB in 2008 using a green light committee, approved a standard 20-month regimen. The Diamond Foundation, a major partner in TB control, has been using a 9-month Mdr-Tb regimen since 2005 and continues to implement this shorter regimen in 26 districts in Bangladesh. PMD in Bangladesh has expanded countrywide, increasing diagnostic and treatment case access to patients. The management approach is community-based, allowing patients to receive supervised treatment in their homes through community providers after initial hospitalization for 4 to 8 weeks. Government of Bangladesh is ensuring TB and DR-TB diagnosis and treatment is completely free of cost. So the support is being provided to all DR-TB patients as nutrition support of 1,500 Bangladesh taka per month and actual cost of external investigation. The DR-TB provider receives initiatives of 1,800 Bangladesh taka per month. Besides, government of Bangladesh, private sector is significantly involved in diagnosis and treatment of TB and Mdr-TB patients. There is a strong referral linkage between private and public sector. 20% of these TB cases were referred by private sector in 2016. Also, the TB patients diagnosed in private sector are being referred to DOT center to ensure TB treatment. Some patients are receiving TB treatment from private sector and are not notified. NTB, along with these partners, are working on ensuring mandatory notification. The health care providers from private sector are referring DR-TB cases to TB reference laboratories and gene expert sites. Besides this, 27 new gene expert sites are being established in private sector under PPM, public-private mix. There are few diagnostic facilities in private sector where Mdr-TB can be diagnosed. But when they are diagnosed, are being referred to PMDT centers. Treatment initiation is not possible in the private setting as the second-line anti-TB drugs are not available in the open market. Currently, government has no plan to make the second-line anti-TB drug available in open market, as independent use of these drugs can lead to additional resistance. After the Mdr-TB patients sent to community, the private sector plays an important role in continuing to this treatment, follow-up and ensuring DOT. The Mdr-TB providers are selected from both public and private sector. The contribution of private sector is more in urban areas. Treatment monitoring is also being done with the contribution from private sector. To ensure more involvement of private sector, NTP under Ministry of Health and Family Welfare conducted centralization of workshop on Mdr-TB in all administrative divisions in Bangladesh in 2016 to 17, including private sector. Government is continuous building capacity in private medical college, hospitals and others big private hospitals on TB and Mdr-TB. TB control program in Bangladesh is one of the good examples of public-private mixed, and we hope to strengthen it more to ensure quality diagnosis and treatment and caring of Mdr-Tb. Our Honorable Prime Minister is very serious about the fight out the TB from Bangladesh. Not a minister, as a politician, I declare that we are very much committed to the people to fight out the TB from Bangladesh, and we will do it. Thank you very much.
Minister Nasim, thank you very much indeed. Clearly, Bangladesh is one of a number of high-burden countries, and as elsewhere, faced with the problem that only a proportion, something like 1 in 5 of the estimated MDR cases are being diagnosed. And so we've heard about the major steps being taken to change the situation, in particular the scaling up of diagnostic capability to find more of the unrecognized cases, the mandatory notification, the collaboration of the public and private sector in the provision of treatment for TB and treatment that is free of charge. As part of that, control of key drug use, including use in the private sector. And finally, and I think really importantly, your comments at the end about the importance of the political commitment at the highest level, and it's clearly really helpful to hear that that is the way that it is going in Bangladesh. So, Minister Nasim, thank you very much indeed for that contribution. I want to turn now to our third ministerial speaker, His Excellency Quang from the Vice Minister of Health in Vietnam. Vietnam has been quick to take aboard innovations recommended by WHO for tackling Mdr-Tb, from new medicines to digital health to palliative care. What are the lessons learned in that process that you may want to share with countries that are at earlier stages in implementing the NTB strategy? And are they relevant to the response to antimicrobial resistance generally? Thank you.
Mr. Chair, Your Excellencies, ladies and gentlemen, according to WHO's estimation, Vietnam is one in the list of the high TB and Mdr-Tb burden countries, with about 120,000 TB cases and more than 6,000 Mdr-Tb cases a year of incidence. In 2014, the government of Vietnam has issued a national strategy on TB control up to 2020 with visions of 2030 that paved the way for intensified interventions focused on implementing the global and TB strategy proposed by WHO. To do that, we set a target of 30% reductions of prevalence and 40% reductions of mortalities within 5 years from 2015 to 2020. We all know that political commitment is most important to provide sufficient financial and human resources, but innovations of technologies and approach is also very important, especially to address on very difficult Mdr-Tb problem. Therefore, we have been looking for new tools for TB control, such as new diagnostic tests, new TB drugs and regimens, new models of management applying digital health. From 2009, we started treating Mdr-Tb programmatically, so-called programmatic management for drug-resistant TB, with small scale. And then we scaled up very quickly. So far, we treated about 11,000 Mdr-Tb cases with more than 70% successful rate. We apply a recommendation of WHO on new TB tests such as Gene Expert, hand tests to detect Mdr-Tb in time and treat them very early to cut down transmission sources. Mdr-Tb management is very challenging due to very long follow-up and frequent drug side effects. To help manage Mdr-Tb adequately, the National Tuberculosis Control Programs has quickly applied eHealth as eTB Manager program that is web-based and case-based recording and reporting, including second-line drugs management and introducing community-based treatment to support patients at grassroots level. Recently, WHO recommends new drugs such as bendakilin and short regimen for treating Mdr-Tb. We try to apply very early stage by doing pilot study with quite good results of more than 80% successful rate. And now we are going to scale up when our system got adequate experience on new technology. To control Mdr-Tb is not only about treatment, but also prevention by strongly management TB as the comprehensive program. The Ministry of Health issues a circular to get all private health facilities involved in TB control with standard care and treatment based on WHO recommendations on public-private mixed initiative. Then, for sustainability, Ministry of Health issues a circular on health insurance mechanism, gradually covering TB control, including Mdr-Tb services. We also expand programmatic management for drug-resistant TB to closed settings, such as in prison, by collaboration with Ministry of Public Security, and develop a mechanism to get patient support as a social protection initiative from Ministry of Labor, Invalid and Social Affairs. Community involvement is also very important to support patients with long treatment. We promote many social organizations to collaborate with TB program to make people understand and to increase accessibility to the standard TB services. By doing that, last year, in 2016, we provided Mdr-Tb treatment for 2,500 cases, and this year will be 3,000 cases in Turkey with high successful rate. In the next 3 years, we try to cover more than 60% of Mdr-Tb patients in the country. Talking about lesson learned, we consider international and regional collaboration is very important. And we have received great support from many international partners. Recently, we have just organized a very successfully APEC Leaders Summit 2017 as the host economy last week. Before that, in August this year, we had a side event of the 7th APEC high-level meeting on health and the economy called Policy Dialogue on Accelerating Action on TB and Mdr-Tb in APEC region. And its region as follows. The 7th high-level meeting recognized tuberculosis as a public health priority in the APEC regions and calls on APEC economies to partner with the civil society, the private sector, and international organizations to accelerate efforts to eliminate tuberculosis. In addition, I should say that the role of the task force on TB and Mdr-Tb with highly committed and competent health professionals is one of the essential factors to contribute to the success of TB control program. Ladies and gentlemen, AMR is a health security threat that needs an urgent response. Among that, Mdr-Tb is fighting initiative in Vietnam. We have a national action plan for AMR response in 2013 to 2020, and again, we need innovation of thinking in that political commitment with multisectorial accountability. In brief, the Ministry of Health of Vietnam has been paying high attention on AMR and Mdr-Tb in particular, and has achieved quite positive results, but need to be more and more sustained actions in the future. On these occasions, on behalf of Ministry of Health of Vietnam and Vietnamese people, I would like to sincerely thank WHO and international partners for your strong and effective support. Thank you for your attention.
Vice Minister, thank you very much indeed. As you heard, Vietnam is another high-burden country and has set about a series of measures to better tackle this problem. And we heard emphasis on involvement of the whole political system, with healthcare, of course, at the center of that, but nevertheless the whole political system, and the need to treat the problem of multi-drug-resistant TB not as business as usual, that there needs to be new approaches, innovation, and we heard about innovation in the application of testing technology, a focus on patient-centered treatment. We heard about the adoption of new and shorter regimes for the treatment of multi-drug-resistant tuberculosis. We heard, not unlike what we heard earlier, about the importance of linking with, collaborating with the private sector. We heard about renewed emphasis on increased investment and on the use of and value of community-based management. Finally, we heard about the importance not just of seeing this as an issue within an individual country, but the importance of regional and international collaboration. Indeed, you went on to mention the concept of multi-drug-resistant TB as a health security issue, something that, as I understand it, you see as part of a wider antimicrobial resistance threat. And that is a theme that I think we will be picking up further during this session. So thank you very much for those remarks. Our fourth ministerial speaker is His Excellency Ganglip, the Deputy Minister of Health and Welfare from the Republic of Korea. Mdr-Tb, the form of antimicrobial resistance that's causing the greatest number of deaths globally, is perceived by many as a national health security threat. And your country, Korea, is now the Secretariat of the Global Health Security Agenda, GHSA. What role do you think GHSA could play in the response to Mdr-Tb, and what do countries have to do to benefit from this initiative? Thank you.
Okay, thank you, Moderator. Excellencies and colleagues, ladies and gentlemen, I'd like to start my short presentation by expressing my appreciation to WHO and Russian Federation for providing this opportunity to discuss the topic of end TB in alliance with Global Health Security Agenda. It is my pleasure to be addressing you on this increasingly important issue. Tuberculosis is a source of great disease burden around the world. Specifically, in the case of Mdr-Tb, treatment is not only very difficult, but the fatality rate of the disease is also very high. As such, it poses a great threat to health security. As Moderator mentioned during the introduction, currently there are an estimated 490,000 Mdr-Tb patients per year worldwide. It is important to note that the risks resulting from such cases are not contained within the border of a given country due to the increasing number of travelers and immigrants. As such, developing an effective and appropriate response to Mdr-Tb cannot be achieved by a single country's effort alone. It is an issue that requires the attention of the entire global community. The Global Antimicrobial Resistance Surveillance System, GLAS, was introduced in 2015 for the monitoring and rapid response of the status of AMR at the global level. Also in September 2016, at the 71st UN General Assembly high-level meeting on AMR, discussions on the severity of AMR led to a resolution promoting collaboration between the media, government, and all relevant sectors to achieve sustained global action as a means of response. In August 2016, the Republic of Korea also stepped up effort in addressing AMR by developing a strategy to promote AMR management policies. Furthermore, as the chair of the Global Health Security Agenda, GHSA steering group, my government participated in the WHO joint external evaluation to evaluate its implementation of international health regulations of WHO and has collaborated with the WHO to provide support to nations in need. Let me talk about GHSA. GHSA was launched in 2014 in collaboration with 29 nations and WHO, FAO, and OIE, and non-governmental organizations for rapid response to the threat of emerging infectious disease, bioterror, AMR, and etc. As of today, 63 nations and 9 non-governmental organizations are participating in GHSA. The targets of the GHSA are comprised of 11 action packages divided into the areas of prevention, detection, and response. These packages consist of evaluations and guidelines for each technical area and also provide recommendations to fill any gaps as required. In addressing Mdr-Tb, various technical areas are involved, such as AMR, national laboratory systems, immunizations, monitoring, reporting, and human resources. The main tool that the GHSA utilizes in strengthening public health capacity is the joint external evaluation, which objectively assesses the current status of a nation's health security emergency response capacity. The main areas evaluated under the JEE include the 11 technical areas. Those are most fundamental to the implementation of the WHO IHR. Participation in the JEE is voluntary, and so far, 61 countries have completed the JEE. My government also has completed it last August. Upon completion of the JEE, a joint official evaluation report is publicized so that gaps can be identified. Based on these evaluation results, countries receive support in developing national action plans to fill these gaps and strengthen national capacity for public health security. In cases when technical and financial support is required to conduct this process, WHO and GHSA countries and the JEE Alliance are prepared to provide such support with the ultimate goal of filling the gap among nations in their capacity for effective response. As many of you might be well aware, we are currently preparing for the second phase of GHSA, or post-2018 plan. GHSA was initiated to be continued until 2018. In order to learn from its experiences and achieve better results, the GHSA is currently holding discussions with many nations for its post-2018 agenda. Mdr-Tb is included as an important area of discussion within the GHSA, and as the chair, will continue to discuss this issue further. Throughout my discussion, I'd like to stress that global health security cannot be achieved by one nation's or one sector's or one agency's effort alone. As such, international multisectoral cooperation is crucial in responding to biological threat from infectious disease. I hope that there will be more opportunities to discuss this at the international level in the future. I thank you.
Deputy Minister, thank you very much indeed. You, I think, have made very clear why we need to consider the risk from Mdr-Tb not just as a risk that is confined to individual countries, but one that has implications for other countries, and that therefore it is a global health security threat. You mentioned the UN declaration last year around antimicrobial resistance and the importance of Mdr-Tb as a part of that. And then what you described about the global health security agenda, I think many will find very helpful indeed, in particular the approach to the rapid response to emerging infectious disease threats, that there are a range of action packages, but what they are intended to do is to strengthen public health capacity, and that a first element of that is the idea of an external evaluation of national capacity. And I can say that the UK is one of those countries that has been through this process, and we found this a very helpful process indeed, to have that external and independent look at our capacity in this area. And then when there are gaps identified in the ability to be able to respond effectively to emerging infectious disease threats, the potential for support to help fill those gaps. And it's very encouraging to hear that now there is discussions underway around the continuation of the GHSA approach with a view to a program from 2019 onwards. So thank you very much for that. I want to go to the last of our speakers from the panel here. Irene Kirk is Senior Deputy Assistant Administrator of the Global Health Bureau of the US Agency for International Development. Irene, your country is the main donor to global response to TB and Mdr-Tb through a variety of interventions, not only within the United States, but of course in the region of the Americas and globally. How do you see your role in the next 5 years, and how that role could accelerate the Mdr-Tb response and the wider antimicrobial resistance response? Irene, thank you.
Good. Thank you, John. First, let me just say I'm so very honored and pleased to be on this panel with such distinguished speakers from around the world. And I also want to echo my colleagues' thanks to WHO and the Russia Ministry of Health for hosting this meeting. It's actually been quite remarkable to hear the discussions over the last day and a half and about how committed everyone is to really moving forward on these important issues. So it's been quite inspiring. My panelists have talked about the really impressive work that's been done to address Mdr-Tb so far, and it's really encouraging and terrific to hear those stories. And as we've noted, it really is the lead, Mdr-Tb is the leading antimicrobial resistance killer around the world. As you mentioned, John, the U.S. government is the global leader in the fight against TB, and it's a major part of our program. We're also the leading donor for global health worldwide. And TB has and will remain an important part of our program. We're very, very committed to this fight, and we're continuing to move forward with all of you. So we've talked about, and just mentioned, my colleague from Republic of Korea talked about, Mdr-Tb is both a national and global health security threat, and very, very much part of global health security, and needs to be core, exactly as my colleague mentioned. And we really need to recognize it as such and let that feed into the attention it gets at country level and the attention it gets globally as well. Mdr-Tb kills, as we know, and we saw on the slide, hundreds of thousands of people each year. And by tackling Mdr-Tb and TB, we are helping develop a platform to tackle other antimicrobial resistance diseases as well as a variety of other issues. So our key messages, one is that, and as we've heard from a couple of countries, it's so important to have a clear plan of action with measurable targets and milestones to address Mdr-Tb. We've seen how that can work at country level, and it's something that is part of what we do at USAID. We're very committed to working with countries to make that happen and to help support that effort. Within the United States, we've also been taking bold steps to tackle Mdr-Tb, both within the United States as well as abroad. 2 years ago, the US developed a 5-year Mdr-Tb national action plan with targets and milestones along a number of different goal areas. And there are goal areas for what happens in the United States domestically, which is led by our colleagues from the Centers for Disease Control and Prevention, what happens internationally, which is led by USAID, and on research, which is led by our colleagues, the National Institutes of Health. These goals are something that we're all very much committed to working together to achieving and working together with all of you. The second area, and this has come up in a number of what's been said by some of the panelists, is the real need to build this coalition of multisectoral partnerships. We really do need, not just globally through international coalitions, but at country level. And that includes working with the private sector, which is so important for Mdr-Tb. That we've seen this in a number of countries and heard this from some of my fellow panelists about the importance of making sure the public sector and the private sector are connected. It also requires the sectors from not only health, but also finance, labor, justice, and other government, non-governmental entities, and particularly, as we heard from Violeta, from the communities and from the patient communities, is critical to be a partner with what happens from the health sector and all these other sectors and working together to address TB. As we've said and get it again, we can't do this alone. We really do need to work together and stop doing business as usual and really push forward as we've talked about. The third area I just want to talk briefly about is developing and rapidly rolling out new tools. There is a research agenda, as we've been hearing, and I think the earlier session today talked about some of the work in research, and that's critically important. But we do also right now have some tools that we need to roll out now. We have better diagnostics, as we've been hearing. We'll get more in the future, but right now we do have some diagnostics that can really quickly screen patients for whether they have drug-resistant TB. And that's critically important that we quickly move out the universal access to those tools. Similarly, improved regimens for treating Mdr-Tb, as we're seeing, and we're seeing more studies coming out showing that we can make a big difference and have better care for patients that not only addresses the disease, but are better tolerated, and this is critically important. So it's really important that as part of our plans at national level and globally, that really does include specific actions and plans to roll out these new tools. It's not just enough to develop them, but we really need to be ready to push them out into the field, push them out through the health services, through community groups, through private sector, and so that they could reach patients as quickly as possible. So the last thing I'd just note is, as we've talked about, MDR truly is a international emergency, and we need to treat it as such. And that does mean, as we've talked about, working together across the board and continuing to do more than just come together and make these commitments at meetings such as this, but taking that forward and working together when we go back home and where we work with our colleagues and putting things forward and working together, we can make a difference on this. Thank you.
Irene, thank you very much indeed. It's clearly very important for us to hear from one of indeed the largest external funder of work in this area, to hear of your support for the recognition of Mdr-Tb as a global health security threat, and your emphasis on the need for clear plans within countries with targets and milestones. And it was very helpful to hear the United States approach to that with a very clear plan. You particularly emphasize the importance of multisectoral working not just with the private sector, but with other government departments, and of course with civil society and the patients that they represent. And finally, I think we would all agree with your emphasis on the importance of the need for further innovation, for new tools, and for then the use of those new tools to tackle this problem. So thank you very much indeed for that. What I'd now like to do is that at the beginning of this session, I mentioned that there were 3 countries whose ministers had been invited and unfortunately were not able to make it. But for 2 of those countries, we have representatives who are here with us and able to offer a few comments about the approach to Mdr-Tb in those countries. And so if we've got a roving microphone, I wonder if we could bring it to the front here, and if I could first of all ask Julia Rios, the National TB Director for the TB program in Peru, to provide some initial comments, please. There's a microphone coming to you there. Can we just help with the getting the microphone switched on?
Buenos días. Soy la doctora Julia Ríos, directora de Prevención y Control de Tuberculosis. Buenos días. Soy la doctora Julia Ríos, directora de Prevención y Control de Tuberculosis del Perú. Vengo en representación de nuestro ministro, el doctor Fernando D'Alessio y Pinza. En realidad, la pregunta y lo que nos habían manifestado con referencia al trabajo de tuberculosis en nuestro país era en referencia a que contamos actualmente con una ley de tuberculosis, la cual ha sido emitida en el año 2015 y reglamentada en el año 2016 y que nos ha servido de marco para realizar una serie de acciones con respecto a lo que es el manejo de tuberculosis resistente en nuestro país.
Could I just interrupt you a moment and just check to see whether we are going to get a translation? Okay, I gather that
Sí.
we will have translation, so please
Comienzo
carry on.
nuevamente. Bueno, como les decía, el Perú cuenta con una ley de tuberculosis, la ley 30.28.7, emitida en el año 2015 y reglamentada en el año 2016, que nos ha servido de marco para tomar una serie de acciones contra lo que es la tuberculosis resistente en nuestro país. En primer lugar, determinar que en nuestro Perú hace muchísimos años que el tratamiento para tuberculosis es gratuito, tanto para la tuberculosis sensible como para toda su forma de TB resistente. Una cosa importante enmarcada en la ley es que está prohibido la venta de drogas de primera línea en el país y todos los tratamientos, tanto para el sector público y privado, lo da el Ministerio de Salud de forma gratuita. Estamos actualmente actualizando nuestra nueva norma técnica de salud, incluyendo esquemas acortados para TB-Mdr. Estamos ya desde el año 2012 dando tratamiento para nuestros casos de TB pre-XDR y XDR con nuevas drogas. Tenemos más de 900 pacientes en tratamiento con drogas como son Inicialid y Bipenem. Y desde el año 2016 estamos dando tratamiento con Velaquilina. Ya tenemos 125 pacientes en tratamiento, lo que nos ha llevado a activar todo nuestro sistema de farmacovigilancia de estas nuevas drogas en el país, ¿no? Una cosa que estamos introduciendo actualmente en la actualización de nuestra norma técnica, lo referente al ingreso de nuevas tecnologías para diagnóstico, como es el GeneXpert. El Perú cuenta con tecnología para diagnóstico de resistencia, el Genotype y el MOTS, pero estamos considerando el ingreso de GeneXpert para poder llegar a los objetivos de desarrollo sostenible. Otra cosa importante establecida en la ley de tuberculosis es lo referente a la multisectorialidad de las acciones para la lucha contra la TB resistente. Nos encontramos actualmente actualizando nuestro plan estratégico multisectorial, en el cual estamos especificando cuál va a ser los compromisos reales tanto de la sociedad civil y de los otros ministerios en la lucha contra la tuberculosis.
realize
Esto es una cosa
what are the
importante para
major
darle
goals
sostenibilidad
for
a todas las
us
acciones que estamos
as
implementando,
the government
siendo una
and for
cosa
the
muy
civil
importante
society. On the other
en lo
hand,
referente a la ley,
we're talking
el hecho
about the
de
comprehensive
que se
policy
establece que
that
el
should be
presupuesto
conducted
específico
here,
para
as
TB
well
es
as the legislative
intangible.
basis
Y eso
that
nos está
should be
permitiendo
installed
hacer
in
un
this
monitoreo
field.
estricto de todo lo que es calidad de gasto del presupuesto de TB a nivel de todas las instituciones del país, tanto
as for the
públicas,
legislature,
interinstitucionales, ¿no?
Regulates the monitoring of our healthcare facilities working in this field.
Bueno, y en último lugar, les voy a hablar referente a nuestro soporte social. Nosotros damos un apoyo nutricional a nuestros 30.000 pacientes con tuberculosis que tenemos anualmente. Es una canasta de víveres que se da a nivel de los gobiernos locales. Y en este año hemos ingresado un soporte social que es dirigido a nuestras personas afectadas con tuberculosis, que son adultos mayores, que reciben un bono económico,
groups of the population,
durante todo el tratamiento de tuberculosis y posterior al tratamiento de tuberculosis. Y finalmente, una cosa importante que estamos trabajando mucho en nuestro país es lo referente a investigación. Hemos formado en nuestra red de investigación, estamos trabajando el Plan Nacional de Investigación en TB para determinar cuáles son las prioridades y los temas que tenemos que investigar en nuestro país, teniendo un especial énfasis en lo que es investigación operativa. Estamos capacitando en investigación operativa a nuestro nivel local. Y este año hemos tenido ya nuestra 5ª jornada científica de lo que es investigación en tuberculosis en el país. Y nos parece importantísimo seguir trabajando en esa área. Y finalmente, la importancia del manejo comunitario y del apoyo social y de lo que es la sociedad civil para darle sostenibilidad a todas esas acciones que estamos teniendo desde el Estado en la lucha contra la tuberculosis resistente en nuestro país.
We focus on
Muchas gracias.
local communities and involve them in the common struggle against tuberculosis. Thank you very much for your attention.
Thank you very much indeed, and apologies for the hiccup at the beginning with the translation, but to be reassured that almost all of what you said eventually came through. So thank you very much for that intervention and very helpful description of the steps that have been taken to strengthen the response to Mdr-Tb in Peru, emphasizing, as some of the other speakers have, the importance of the application of modern technologies, the working together of different departments within government across countries. And you emphasized as well, in particular, the need to ensure that groups at special risk, vulnerable groups in remote areas and the like, that they are cared for as well. So thank you very much for that very helpful intervention. And secondly, I'd like to move to the other country from where we have a representative, Tawhid Islam, works for WHO in Papua New Guinea, and is going to give us some remarks as well. Please, Tawhid.
Thank you. Thank you for this opportunity, moderator, honorable panelists, and colleagues. Thank you for the opportunity to share the experience on behalf of government of Papua New Guinea. In 2015, government of Papua New Guinea, after realizing their burden of Mdr-Tb in specific hotspot areas, they declared that as an emergency. And that emergency created a very high-level committee called Emergency Response TB, which is a multisectoral body and involving the partners. So it's a partnership forum where WHO worked as the secretariat. These emergency declaration actually leverage additional funding, a substantial domestic funding, and also external funding. And these also foster partnership and strong commitment from all the implementing partners. I believe that this example of declaring emergency from the very high level government of Papua New Guinea clearly set up an example that how Mdr-Tb can be addressed in a difficult situation like Papua New Guinea. This created, at least in one hotspot area, a very strong patient-centered care involving community. Though we realize that this is happening only few hotspot sites in Papua New Guinea, the challenge is how this emergency situation and the emergency response can be expanded nationwide, because MDR-TB is a problem of nationwide for Papua New Guinea. Thank you very much for this opportunity.
Tahir, thank you very much. And in particular, I want to pick up on the comments that you have made about the use of the declaration of MDR-TB as an emergency within the country, leading to the emergency response TB. And I think that that's very interesting. You talked about the value of that in leveraging additional funding, creating partnerships, and getting commitment. And I wonder if I could turn to our other panel members and invite them to comment on this suggestion about the potential to declare MDR-TB as an emergency within a country, and related to that, the declaration of MDR-TB as a health security threat, and whether you feel that in your own countries this is something that you can and would do, and that it would be helpful or not. And I wonder, first of all, whether any of our panelists representing countries would like to comment on that. Is there anybody who would like to start in response to that? If I could turn to our Korean colleague, who, and you emphasized the importance of the global health security agenda, and as part of that was the notion that MDR-TB be characterized as a health security threat. You've talked about that in the context of collaborations across countries, but do you feel that within a country the designation in that way, or the designation of MDR-TB as a health emergency, is something that is important and useful?
Okay, thank you. As I mentioned during my short presentation, MDR-TB is a very serious health threat, and from the perspective of health security, and also not only among the GHSA steering group or the GHSA discussion, but at the national level, in my country, we set up the new plan for the strengthening our capacity to respond to the TB problem, because even though compared to other diseases in my country, the TB is a big health threat. So we established a multisectoral national plan, which invite all the relevant ministries to work for the effective and efficient response to the TB, and especially the MDR-TB. And at the area of the GHSA, the MDR-TB is also discussed very seriously, and the target and value of GHSA discussion is how can we support each member country to move toward the better response and preparedness, especially for the infectious disease such as MDR-TB, with the support from not by the GHSA and the other international agencies, but also with the partnership with the private sectors.
Thank you very much indeed. Irene from the United States, did you want to comment on that?
Yeah, in response to your question, John, I do think that either, as we heard from Papua New Guinea, the declaration of Mdr-Tb as a national emergency or including it into the Global Health Security Plan can really be an important galvanizing force to get action and to get the attention, both of not only within the Ministry of Health, but more broadly, which is what you really need to have happen. You know, by its nature, global health security already is a multisectoral approach. You typically have ministries from a number of different sectors, from environment and from security and from labor or from agriculture. But it is then can be a really important forum for bringing those other sectors together to take action, or as we heard in Papua New Guinea, taking real attention to the issue to move forward. And as we've been hearing over the last day and a half, political commitment is so critical to getting that kind of real accelerated action. And if that's what it takes to get that kind of commitment, it's certainly something to, as a tool to use to move forward.
Thank you. And I wonder whether our civil society representative has a view on this issue.
Of course, what I said earlier is very true. We want to be partners, but we also have to respond to our constituency, right? And whenever a country declares an emergency, we expect that to be translated into actions. That's the name of the panel, actions, right? Otherwise, it's more rhetoric, you know, and with due respect, I want to just mention the example of Peru. We know the commitment of the government, but at the same time, there is a letter circulating asking for surgeries of 124 people who are affected by Mdr-Tb right now. And these kind of things I know you're trying to solve, and it's just an example of what are the challenges after we declare an emergency, but then we have to actually make things happen. Otherwise, people may die very soon, right? So go ahead, declare the emergencies in your country, but then the resources have to come right after. We are talking about people who may die very soon. It's not a political declaration. We need declaration, we need political will, and we need resources, like in a real emergency when a tsunami is coming to our countries.
Thank you very much. If you'd like to respond, you're very welcome, but otherwise, have we got the roving microphone, please? And so I'll invite our colleague from Peru to respond to that, and then I'll open it open to questions from the floor.
Buenos días. Lo que hemos determinado que son las acciones que estamos teniendo con referente a lo que es TB resistente y son reales, las estamos trabajando en este momento. Con respecto a las cirugías en pacientes afectados por tuberculosis, la cirugía es un tratamiento complementario. Los 134 pacientes que tuvieron indicación de cirugía para tuberculosis desde el año 2015 a la fecha se encuentran actualmente en tratamiento, de los cuales 36 ya han salido de alta y tenemos actualmente 84 en tratamiento con buena evolución y que están a la espera de acondicionarse una sala de operaciones para reevaluarlos y ver cuál del total de los 84 pacientes requieren actualmente tratamiento quirúrgico o no. Del total de 134 pacientes del año 2015 a la fecha han fallecido 3. Y como les digo, el Ministerio de Salud tiene dentro de su agenda este problema que es un problema principal para el país y nos encontramos trabajando ahorita para tomar la mejor decisión de dónde se va a realizar esta adecuación de la sala de operaciones, ya que lo que le queremos dar es sostenibilidad a esta intervención, no como intervenciones anteriores en las cuales se acondicionaron salas y que después de muchos años se dejaron de utilizar para tuberculosis. La idea es que todas las acciones que estamos tomando y que estamos trabajando sean sostenibles en el tiempo para este grupo de pacientes. Gracias.
To mobilize all the government resources to respond to such cases on a timely basis. Thank you very much.
Thank you. And we got some of that translation, and that was, at least as far as English is concerned, and thank you for that. But I'm sure there may be more discussion between you that might take place. We've got a few minutes for any questions from the floor, and we have a roving microphone. So if I could ask you to say who you are and where you're from, and then give us your question.
Thank you. I'm Dr. Sunita Naredi. I work at a hospital called Apollo Hospitals. It's a private hospital in a city called Hyderabad in India. Thank you for the excellent session and the meeting. When we talk about Mdr-Tb, it's definitely more challenging. And when you talk about Mdr-Tb in extrapulmonary TB, it's even more of a challenge. Now, the burden of extrapulmonary TB is definitely higher in the private sector. Okay, that's probably because of a selection bias. Okay, when you're dealing, most of the information that we have in terms of how to handle Mdr-Tb, the limited data we have, is primarily related to pulmonary TB. We have very little information as to how to go about managing Mdr-Tb or XDR-TB if it's extrapulmonary. It's much more challenging. Not only, and here I'm seeing almost every speaker talking about engaging the private sector in management of TB, because without that, we're not going to be able to achieve our goals. I'm grateful that the WHO, along with the union and Eli Lilly, has invited me here. I have met a lot of people, but I'm yet to meet somebody, a physician who's working from the private sector in this place. Now, do we think that's a problem, not engaging with the private sector?
Thank you very much for those questions, and let's hold those comments, and it may be that the panel will come back on that. We have another question here in the front, please. And again, can you tell us who you are?
Hi, my name's Ann Ginsberg. I'm from ARIS, and I want to thank the panelists for their thoughtful comments this morning. We've heard in earlier sessions today and from Minister Motsoaledi yesterday that a new effective vaccine would be the ultimate game changer for the TB epidemic and crucial to meeting the Sustainable Development Goal by 2030. The same's true for the growing drug-resistant TB crisis. An effective vaccine would prevent drug-resistant TB just as well as drug-sensitive TB. Several panelists have asked for new approaches and innovation, but the word vaccine hasn't been mentioned a single time in this session. Improved treatments, faster diagnostics, patient-centered care are all crucial elements of solving the drug-resistant crisis. But history tells us we will not treat our way out of this problem. Developing an effective vaccine, we believe, is a crucial element if we're going to beat drug-resistant TB. And I'd be interested if any of the panelists would like to comment on that as well.
Thank you very much indeed for that comment and question as well. And if I could turn back to the panel and see if any of the members of the panel would like to comment on the questions that are being offered. I can see Irene at the end nodding. So if you'd like to comment, Irene, and then if anybody else, then I'll bring them in.
All right, thank you, John, and thank you for those two questions. Let me just, on the first question, and my short answer would be absolutely the connection with the private sector is critically important, including for addressing extrapulmonary TB, but as you note, it is harder to do that given issues around diagnosis and other things, but I think that's also part of a comprehensive connection between the public and private sector, also has to address all forms of TB and care for patients. And again, as we talk about, and we've talked about this importance of patients at the center of care, and that does include whatever the issues are with that patient, whether it be extrapulmonary, MDR, latent TB, et cetera. We really need to be looking at it in that sense and trying to push our systems in that direction. With regard to vaccines, and you actually didn't talk about any tools in specificity, but you're quite right, Anne. The vaccine, as we talk about new tools and the need for new tools in TB, we typically do talk about diagnostics, drugs, and vaccines. And so I would very much agree in principle that vaccines are a critically important part and a critically important tool. I think one of the issues and the practical issue is that we are still a number of years away from a vaccine, and we've been talking about the need for action right now on Mdr-Tb. So I think it's less a one or the other, but a dual approach, and looking at what can we do right now and trying to reach patients who are now facing Mdr-Tb today, which we can't. Vaccines aren't there yet, but certainly we do have better diagnostics, and we're working on better treatment protocols and better treatment regimens, and that's what we need to do now. But we can't, as a global community, lose sight of the need for investments in vaccines and hopefully pushing that a little bit faster through the research pipeline. Thanks.
Irene, thanks for those comments. And if no one else on the panel wants to comment, I'll bring others from the audience in. Violeta?
I don't remember if I told you I am the board member for the communities delegation in Unitaid, and they are sitting there. I know if the vaccine is ready, I think Unitaid will be investing on that immediately. But sadly, Unitaid is not now doing investments on research and development, but just bringing innovations quickly to the communities. So I think the communities, the civil society, and you also, the governments, we need to push developers to develop this vaccine. And then once it's ready, it will be taken up by Unitaid and then the Global Fund. That is how it's working. And I know that commitment is there. There are 2 people from Unitaid there, and maybe in the near future, they will also be investing in developing new tools, hopefully.
Thank you very much for that comment. And just to the first question, let us at least note, if we don't respond specifically to your comments about extrapulmonary TB and Mdr-Tb and some of the special challenges that there are there, which is a very well made point. Thank you. So could I come to the front row here and invite a comment?
Yeah, thank you. My name is Dr. Giorgio Roscigno. I'm from Next to People. And I just wanted to make a comment mixed with the statement. I just would like to have some input from the panel, from distinguished panel, which I thank very much for the wonderful presentation. And this is about prevention of Mdr-Tb, because I think we're talking a lot about treatment and how do we tackle it, but I have the impression that prevention of Mdr-Tb should be really the focus of all our talks. And if we look at this as an emergency situation, the first thing is that countries should know why are they having Mdr-Tb, identifying the cause and addressing the cause. And finally, also to Irene, isn't not the time also to have indicators on prevention of Mdr-Tb so that we know which are the causes, we have a clear plan of how to address the causes, and then really have an indicators of how well are we doing to address these causes, because we are creating resistance to the only 2 effective drugs we have, rifampicin and INH, in front of a situation that, maybe in the next 5 years we'll have a new regimen, maybe in 10 years we're going to have a new regimen. And if the progression of Mdr-Tb goes at the current rate, in 10 years we're going to be in a real, very, very dramatic situation. Thank you.
Thank you for that comment, and I wonder whether any of our panel would like to comment on that.
Mr. Moderator,
please.
I comment on other things. I'm a doctor, I'm a politician, but from a long time I'm a health minister and a citizen of the country. I feel tobacco is one of the source of TB. You please advise from WHO, all the countries, the non-smoker should be health minister of this country. Non-smoker should be health minister of that country. I'm a non-smoker. So I feel that smoking is one of the reasons of TB. Thank you.
Thank you very much for those comments, and definitely noted, and I'm sure WHO colleagues as well will have picked up on those. Anyone else from the panel want to comment? Irene?
Now, just in response to Dr. Rosinho's comment, and I would very much agree, the prevention of Mdr-Tb is incredibly important, as well as the diagnosis and treatment of current MDR patients. But we have to do both, right? We have got to prevent Mdr-Tb, and part of that, as we've said for many years, is having good TB programs, right, that patients are diagnosed and treated effectively for TB. But we also see a lot of transmission of Mdr-Tb as well. So it gets back to your point, I think, about what are the indicators, what do we know about it? And I actually asked panel and others about what are some of those things we can monitor to watch, but it's absolutely something we have to pay attention to and has to be part of those action plans at country level that we really do, and as well as globally.
Thank you very much. Now we have to bring this session to an end. It's been an excellent session, and there's no way that I can summarize all the many very valuable points that have been made. But certainly by way of headline, we've re-emphasized the tremendous gravity of the situation presented by multi-drug resistant tuberculosis. We've heard some really striking examples of initiatives in countries to move forward on this, in particular the need to bring together different parts of countries, a multisectoral response, and to have clearly laid out plans, and as part of that response to employ new tools and apply those effectively. But we've also had a reminder about the importance not only of effective treatment of MDR-Tb, but also of the value of preventing people from being infected in the first place, and as part of that, the potential game changer role that a vaccine might play. And then finally, we've heard about how, in order to ensure that the response fits the size of the problem, that it may be important, particularly in high-burden countries, to use the machinery of emergency, of declaration of emergency, and the recognition of the health security threat presented by MDR-Tb as a way of mobilizing political will and resources to better be able to respond to the MDR-Tb threat. So thank you very much. I'd like to ask the audience to thank our distinguished panel for their excellent contributions. And thank you, too, to the audience for coming along and for your own contributions as well. Thank you. And finally, before you go, I've been asked to tell you that they're going to do a changeover in this room during now the lunch break. So please, A, could everybody leave straight away? And B, make sure you take everything with you when you leave. So thank you very much indeed. Goodbye.
I'm living more concerned. You know, the friend is...
I guess